Hello, everyone. My name's Senna. I'm currently a medical student at McMaster University. I'm here with Dr. Donnellan today, who is a staff pediatric interventional radiologist at McMaster Children's Hospital. He has very kindly agreed to share his career journey with us. This video is a part of a series created by the Canadian Association of Radiologists Medical Student Network to just help medical students understand a little bit more about the different fields of radiology. So thank you so much for being here, Dr. Donnellan. We really appreciate it.
No worries, anytime.
The first question I have for you is just if you could tell us a little bit more about your path to radiology.
Sure. So you may guess by my accent that I'm from Ireland originally. So I undertook my radiology residency in Ireland. So I did med school. I then did 2 years of surgical training because I thought I wanted to be a pediatric surgeon. And then I moved into radiology, and I did 5 years of radiology training in Ireland, which was diagnostic and interventional. And then I undertook a fellowship in pediatric interventional radiology at the Hospital for Sick Kids in Toronto, which was 2 years. And then I very luckily just found a staff job as a pediatric interventional radiologist here in Hamilton shortly after that. So I was always a kind of a proceduralist type of person. I always wanted to be doing things with my hands, which is kind of how I started out in surgery. And then I realized that, what I really enjoyed doing was kind of the minimally invasive stuff. And so I really started my radiology residency in the hopes and knowledge of becoming an interventional radiologist at the end of it. So, yeah.
What drove you to come to Sick Kids?
Yeah, so it's interesting. In Ireland, where I was doing my training, there is no pediatric interventional radiologist in the whole country. And so I came to do a fellowship, hoping to kind of turn around and go back to Ireland and be the first, full-time dedicated pediatric interventional radiologist in Ireland. But after being in Sick Kids for really about 6 months and living in Canada and in Toronto, I kind of just fell in love with Canada and the way of life over here and how nice everybody is. And so I decided to apply for what's known as permanent residency. So I got my permanent residency while I was on fellowship in Sick Kids and really just stayed around, right? And here I am almost 10 years later and I'm still in Canada. So yeah.
Well, we're really happy to have you here. Is the training process to become a pediatric interventional radiologist similar here in Canada as well?
Yeah, it is. So for most places, we still do a combined, predominantly diagnostic radiology training program for everybody as part of the radiology residency. It's predominantly diagnostics. You do get exposure to interventional radiology during your undergraduate training or during your residency training here at McMaster. And when you finish, if you choose to go down the path of interventional radiology, most of the time for most people, it's a 1 to 2 year fellowship dedicated in interventional radiology after your residency is over. And so it's slightly different if you want to focus on pediatrics, because all the residency programs, while you do get some exposure to peds, it's not enough to say that you're a pediatric radiologist when you come out at the end of your residency program. And so you usually have to do at least 1 year of dedicated pediatric radiology, diagnostic radiology fellowship first. And then if you want to do pediatric IR, you do another 1 to 2 years on top of that in terms of pediatric interventional radiology. So really it is, if you want to do pediatric interventional radiology, which is super niche, right? I get that I'm like, kind of like a unicorn, right? Like there's not many people that do full-time pediatric IR out there. But in the Canadian system, you're looking at kind of 2 to 3 years of fellowship after your residency in order to qualify for it.
So quite a bit of training then.
Yeah. Yeah, but it's great. It's a wonderful job. I wouldn't change it for the world.
Amazing. Can you tell us a little bit about a day in your life?
Sure. So I'm quite lucky insofar as I do 3 days a week of pediatric interventional radiology. So that means that I'm in the operating room doing procedures, doing cases all day long on those 3 days. The other 2 days of the week, I do 1 day of pediatric diagnostic reporting on my Tuesdays. And then because I'm also the chief of radiology at McMaster here, I also get an administrative day, which is my Thursday. So Monday, Wednesday, Friday, I'm in the room doing procedures, seeing patients, doing the fun stuff of IR. Tuesday is my fun day of diagnostic, emergency, and inpatient reporting. And then Thursday is my admin day.
Very cool. What kind of procedures do you usually see throughout your day?
So when I was training in my radiology residency back in Ireland, one of my mentors at the time is a fantastic radiologist. His name is William Torgiani, and he was an interventional radiologist as well as a diagnostic radiologist. And he really thought of IR as being kind of the Wild West in terms of when nobody else can fix it, maybe IR has a solution for it. So a lot of what I do is vascular access, so things like PICCs, ports, dialysis lines, things like that, in very small babies. And that's kind of a special interest of mine, right? So when I say very small babies, we're talking about like 400, 500 grams, that kind of size, right? So really tiny little prem babies. And then after that, I do things like gastric access, so things like G tubes, GJ tubes. We also do biopsies, predominantly liver and kidney, looking for tumors in kids. And then after that, I also run a clinic in vascular anomalies and pediatric birthmarks. Because there's a huge amount of work that's happening with children with birthmarks now, and there's lots of new treatment modalities that you can provide as an interventional radiologist to help these kids. And so that's great because it actually allows me to work in a bigger clinic with pediatrician, dermatologist, hematologist, oncologist, plastic surgeon. We all work together and we run the clinic once a month for the birthmarks. So it's really fantastic to be able to do that kind of work as well.
So you would say you have quite a bit of patient exposure then?
Yeah, it's interesting. So like one of the myths about radiology is that like you sit in an office and you look at x-rays all day and that's all you do. And it's kind of like a 9 to 5 office job. And certainly you can have a degree of that if that's what you want. But in the world of pediatric radiology and certainly in the world of interventional radiology, you spend most of your day with patients. I spend most of my day kind of talking to parents of kids, talking about consent, what the procedure is involved, what are the other options rather than just going ahead and getting the PICC line put in. Is there other things that we can do for the child? And so you spend a lot of your day actually talking to patients. And so you don't lose that piece of being a physician seeing people just because you're doing radiology. But certainly it is nice. So on my Tuesday, when I'm doing my diagnostic reporting, yes, I'll go to ultrasound and I'll scan some patients if the sonographers are having a challenging case or they want me to look at pictures with them. But I can certainly sit in my office for a few hours and do some reporting and kind of have a bit of downtime as well if that's what I want to do. So radiology is really nice because it gives you that ability to balance your workday in terms of what you really want to achieve.
Mm-hmm. I think that's amazing. I think a lot of medical students come into medical school thinking it's just sitting alone in a room, but you're showing us it's not. So that's great.
Yeah, absolutely. I mean, the running joke about radiology is always that it was art appreciation, right? That you sat in a room looking at pictures all day and that was it.
Mm-hmm.
But honestly, the way that medicine is evolving and the way that radiology is evolving, that's becoming further and further from the truth, right? You can spend your whole day with patients if you wanted to. You wouldn't get as much reporting done in your day if you did that, but certainly you can have as much patient exposure as you want.
What do you think the biggest challenges of your job are?
So I have two hats, right? And so the biggest challenge of my job as a pediatric interventional radiologist is trying to navigate what is the best thing for my patient in the face of what the parents might want, in terms of what the MRP, most responsible physician, might want, in terms of what other people think you should do. And that is interesting, particularly in Ontario, because we don't actually have a minimum age of consent here. So that means if you have a child who understands what's involved with the procedure and they don't want the procedure, but if mom and dad are insisting that they have it, you have to go with what the child wants, right? And so that can sometimes be a challenging discussion to have. But most of the time, you don't have to go down that path, and you explain to the patient exactly what you're planning to do and how you're going to help them. And so that's a piece that can be challenging from time to time. The other part, specifically in pediatrics, is resources. Because about 70% of the IR work that I do needs to be done under general anesthesia, I need to make sure that the hospital can provide me an anesthesiologist in order for me to do my work. And so that's one of the challenges, is kind of the logistics parts of working in a hospital. And then the last part is with my administrator hat on, is always, no matter what field of medicine you go into, one of the biggest challenges is always dealing with people, dealing with your colleagues, right? And interpersonal things that happen between people. So, just making up an example, I come in to report the emergency list on Tuesday, and the person who was on it on Monday left 30 things behind on the list. And so I come in and inherit their work. And then I get all upset because, it's not my work to be tidying up after somebody else. And that is the same no matter what part of medicine you go into, right? There's always going to be those challenges with colleagues. And honestly, usually a phone call or a text message kind of sorts it all out. And you're like, hey, did you intentionally do this? And they say, oh, no, I totally forgot. And then that's it, right? But don't expect that you're going to be able to come into radiology and just have 9 to 5, Monday to Friday. This is what I do, right? Because medicine is not like that.
Right. Definitely challenges I did not consider. Being one of the very few pediatric interventional radiologists in the world, what's your work-life balance like?
It's great. Honestly, it's fantastic. Working with children is really, really fulfilling. It's really satisfying because most children, when you deal with the acute problem that they have that brought them to hospital, they don't have another list of comorbidities. So they go home after you fix that one thing and they get better, and hopefully you never see them again, right? For the children that do come regularly, right, the frequent flyers and the people that come to see me, for example, for GJ tube changes every 4 to 6 months, it's great because you get to build a relationship with them, and you know them, and you know their parents, and it's kind of like seeing your friends coming through the hospital all the time. So that's really, really nice about working with children. The other good thing is that most children are not involved in motor vehicle collisions at 3 o'clock in the morning because they're all at home in bed. And so unlike in the adult IR world, where you're being called in the middle of the night all the time to do bleeding, tumors and motor vehicle collisions and traumas and things like that, in the world of peds, you rarely get that kind of work to do. So your daytime job is really, really busy. But when you go home at 7 o'clock or 8 o'clock in the evening, for example, after your day's work is done, you usually don't have to come back to do stuff in the middle of the night, which is really, really nice from a proceduralist perspective, right? So if you're the kind of person that wants to be doing procedures, that's a really nice thing to know that when you go to sleep at night, it is rare that you're going to be woken up in the middle of the night to come in for something. Okay.
How often do you think you're on call roughly?
So I am on call 1 in 3. Right? That's the frequency of my call. But like I said, my 1 in 3 call is very different to my adult colleagues who are 1 in 3, 1 in 4, 1 in 5, 1 in 6, because you can guarantee that they're getting up in the middle of the night to come in to do something at 12 o'clock or 1 o'clock in the morning. When I finish, yes, when I'm on call, I will stay and I'll do a long day. So like I said, till maybe 7 or 8 o'clock. But when I go home, rarely will I need to come back in the middle of the night. Right? So it's a very different type of call.
Okay. Speaking of adult interventional radiologists, how do you think your job differs from them aside from the very office patient population?
Yeah, it's different. So the types of pathology I see is very different, right? And the types of thing that I get asked to do is very different. So in the adult world, there's lots of trauma. There's lots of oncology work. So you're embolizing liver tumors and bleeds and things like that all the time. You do an awful lot of arterial work. In the pediatric world, the stuff that gets you brought in the middle of the night, the stuff that's emergent for you to do, a lot of the time it's vascular access, right? It is, like I said, a 400 or 500 gram baby, and nobody can get an IV in, and the baby is, doing not so well because they're becoming dehydrated and they can't get their IV antibiotics for their osteomyelitis or meningitis or whatever. And you come in with a very specific skill set, which is ultrasound and needle guidance, and you get an IV for them, and it can really change the course of that child's trajectory in hospital, right? So it seems like a very simple thing, but to get to the level where you can, reliably do that in an emergency in the middle of the night on somebody who's teeny tiny and your target is less than a millimeter, it just takes practice, right? And so that will be one of the big differences between pediatric IR and adult IR is the type of work that you do, and then also the kind of targets that you're aiming at, right? Obviously in pediatrics, they tend to be a little bit smaller. Okay. The other piece to think about is when you're dealing with adults, the conversation is usually easier because you're dealing directly with the patient and they get to make a decision for themselves about whether or not they want to go ahead with the procedure. In the pediatric world, like I said earlier, you want the patient to agree and to go on and do it if it's the right thing for them. But oftentimes, for babies that are newborn, you're dealing with mom and dad who are making a decision about, what to do for their child. And it is really, really difficult when you have to make a decision for somebody else. because you're taking on the risk of that procedure. But it's not for you, it's for somebody else. And so it becomes challenging kind of, those conversations, because mom and dad just want to do the best thing for their kid, and you're there to try and facilitate that as best you can. But, that is a little bit different. The conversations are a bit more nuanced.
Right. You essentially almost have two patients to consider there.
Yeah, absolutely. But I find that parents, they're not really patients. They're more so just guilt-ridden with having to make decisions about their kid, right? Because they want to do the best thing. And it's very hard for them to sometimes make that decision. And you're there to try and help and guide them along the way, right? But in my job, I kind of parachute in when somebody's really sick or needs a very specific thing done. And, in the 5 minutes I have to talk to mom and dad, I have to try and build a relationship with them, get them to trust me, and hopefully they'll believe what I'm telling them, and trust that what I'm offering is in the best, intent for their child, right? And so that's an interesting piece, because you have to build that rapport very, very quickly when you work in a consult-based type of specialty like radiology, right?
Right.
You've got a very small time window to actually try and build a relationship and get to the bottom of what the patient really needs.
Amazing. Knowing that pediatric interventional radiology is relatively new, what kind of advancements do you think are going to come in the future?
Yeah, it's amazing. Even the stuff that's happened in, let's just say, the last 10 to 15 years has been, I never saw it coming, right? So I didn't think when I started doing pediatric IOR that I would be involved in pediatric birthmarks, for example. And now it's one of the things that I love to do. But even then, we started doing injections, so sclerotherapy, for some particular types of birthmarks, which has been really, really useful for certain patients. But even in the last kind of 5 to 10 years, some of that work is being replaced by medication and tablets, right? And so we can now give tablets to help cure and improve, I won't say cure, but help improve symptoms for patients, which previously would have required surgery or sclerotherapy in order to assist them. So, the medical side of things, particularly with genetics and genetic profiling and things like that, is coming a long way with, targeted therapies for patients. And then the other part of all of that is AI. Now, AI is the part that everybody's expecting me to talk about. But if you are somebody who puts needles into things for a living, AI is not at the point yet where it can do that, right? And so certainly if you were doing full-time diagnostic radiology, probably before the end of my career, which hopefully will go another 20 years at least, we will probably have AI adjuncts in every department, right? Helping us guide towards making more informed decisions and diagnoses. In the interventional radiology suite, there still isn't a great amount of AI tools that are in widespread use yet. So it's a few more years before interventional radiology will fall prey to AI, but it's definitely coming, right? Certainly it's going to help us. I mean, there's a whole journal published just last week that I got delivered onto my desk today, which talks about using augmented reality and virtual reality for visualization of targets for doing biopsies, right? So there's certainly a lot of very cool high-end tech stuff that has come through. But it's probably another, I would say, 10 to 15 years before we'll see that in regular use.
Okay. So what I'm understanding is you're saying it's going to help you with your job.
Correct. It's not going to replace us, but it certainly will be an aid for targeting, for localization, for trying to biopsy the active part of the tumor as opposed to the necrotic part of the tumor. Those kind of things will come in first, and then yes, in 30 years there might be a robot that can put in PICC lines better than I can, right? So.
What kind of advice would you give trainees that are interested in radiology, interested in pediatric interventional radiology?
Sure. So just get out there, just see it, right? Try to get into as many departments as you can, not just one department, right? Try to see lots of different things, and keep your mind open to different options that you have available to you, right? Radiology historically in most medical schools is a kind of an underrepresented subspecialty, right? So you tend not to get a lot of exposure while you're in med school, and then you start in residency and go, oh, wow, I really wish I had known about radiology. And, we get people that way as well. But certainly go around and see what it's like, because working as a radiologist in an academic center like I do, like I said, I'm very, very fortunate to work where I work. It's a wonderful hospital. It's a wonderful department. And I get to do what I love for most of the week, right? Which is really great. But that's a very different life than somebody who works in a community hospital and has to cover neuro, MSK, adult, peds, everything. And that's very different to somebody who works in, for example, an imaging clinic where maybe all you do is MSK reporting, musculoskeletal reporting all day, every day, right? There's a whole host of different things that you can go into and subspecialize in from within radiology itself. So just try to get out there, see as much as you can, keep an open mind as to what might interest you. And decide if working with kids is something that you want to do, right? Because like I said, it is a longer training path if you're going to do dedicated pediatric imaging, right?
Wonderful advice. Thank you so much. Are peds IR able to work in the community as well, or is it mainly academic sites?
It's mainly academic sites to do full-time pediatric IR, right? Because in the community, there's probably not as much need for the high-end pediatric work. But certainly if you're interested in being a proceduralist and you want to do, adult interventional radiology, absolutely, there's tons of work out there in the community. And if you're the adult interventional radiologist who doesn't mind putting a PICC line into a pediatric patient, that's certainly a skill set that would be valued, right? Because nobody wants to have to send their patient from their community hospital over to the tertiary referral center just to get a small procedure done and then transfer them back, right? It would be great if you can do that. But again, like I talked about resources and logistics, you have to be working in a community hospital that's willing to support having pediatric patients as well, right?
Right. Okay. And maybe we'll just end off with, what do you think is the most rewarding part of your job?
100% it's the kids. The kids are great. Honestly, they fill your day with joy and laughter and giggles and telling silly jokes. And even the sick ones, right? Like they want to kind of chat with you, they want to play. And your job is a lot of fun, and you're seeing them in the bad times, and then you're also seeing them in the good times. So for example, a lot of what I do is put in ports, right, porticats in children with new diagnosis of different types of tumors. And it's really great when you get to see them kind of 3 to 5 years later. They come back to get their port removed because they're finished all their chemo and they've cured their cancer. And so that's one thing I should point out, that one thing, that in the adult world, when people have an oncologic diagnosis, we talk in terms of like 5-year and 10-year survival, right? In pediatrics, we talk about cure, because most, not all, but most of the oncologic diagnoses that kids get, they are curable. And the cure rate in Ontario is greater than 85%. So most of the kids that I see do come back to me 5 years later or 3 years later or whenever to get their ports out. And it's really nice. It's really good to see them doing so well. And that you had a tiny little part in helping them get to the end of their recovery, right? So it's really good from that perspective. And if anybody thinks they might be interested in pediatrics, just come, spend a bit of time in a pediatric hospital, see what it's like. And I guarantee for most of you, you won't regret it.
Amazing. Thank you again for taking the time to tell us about your amazing journey. We really, really appreciate it.
No worries. Happy to chat to you guys. And hopefully I'll see some of you come through as pediatric interventional radiologists in the future.
Amazing. Oh, have a great one.
Thanks, you too. Bye.